Hello, everybody, and welcome to today's United States of Care event, Increasing COVID-19 Vaccine Confidence by Meeting People Where They Are. My name is Natalie Davis, and I'm a co-founder and managing director for public engagement at United States of Care. First, thank you again for taking your time to join today for a valuable conversation. And of course, thanks to the amazing panelists who are giving their time and expertise to us all today. United States of Care is a nonpartisan, nonprofit organization, and we work to ensure that everyone has access to quality, affordable healthcare, regardless of health status, social need, or income. The healthcare system isn't working for millions of people in the United States, and our research shows that people want a better healthcare system in the wake of this pandemic. In fact, we believe there may be an opening for healthcare reforms that weren't possible before this. Core to our work in changing the healthcare system and driving lasting policy change is listening. And without a doubt, some of the biggest issues for our country in the months to come will be vaccine education, outreach, and distribution, and tackling current inequities. United States of Care is taking a critical role to offer trusted, evidence-based messaging to encourage vaccine uptake, including among hesitant or skeptical populations. And as I said, this all starts with listening. How to approach talking directly to people and how that differs across populations, and in some, how to meet people where they are. While there are some people who are jumping up to be vaccinated, there are a lot of people who have concerns, and as supply ramps up, it's especially important that we focus on meeting people's needs and reducing disparities. Concerns about the vaccine and are real and deserve empathetic, straightforward answers and must be heard. United States of Care's mission to ensure that everyone has access to quality, affordable healthcare has never been more important than the current pandemic. When the pandemic started, we shifted our resources to provide immediate support and federal government, leveraging our expertise, network, and resources to meet the effective response. Now, a year into our response work, we have achieved a number of successes through this challenging time. We have supported both administrations in understanding the unique and shared needs across communities. We partnered with COVIDstrategy.com to bring reliable information to the public on the virus spread. And of course, we created and released valuable resources for state and federal officials and healthcare leaders posted to our COVID-19 hub, and continue to make policy recommendations to Congress. And now, as the nation turns to vaccine distribution and education, we continue at United States of Care to play a vital role in making sure people's needs for accurate information are met. We're doing this by leveraging leading research and community experts, activating our influential partners on our board, our Founders Council, our Entrepreneur Council, our Hospital Affinity Group, and our Voices of Real Life. We are working closely with leading researchers and advocates to keep a pulse on the stance of the public, aiming to advise future public opinion work, connecting dots across research and outreach, and publishing our findings and recommendations. We have a speakers bureau of experts armed with evidence-based information. And just last week, you can find on our website, we published a memo to interested parties for leaders, media, influencers, and advocates to bring together the evidence of concerns and tested messages to support all of your efforts. We hope people on the call today will find that valuable. And of course, we'll be bringing experts to the public like today, and you'll hear 4 great perspectives from leading researchers and community leaders. My hope is that through today's conversation, you walk away with more information on the importance of listening to people's concerns, what those are, and how they can be addressed. That you walk away understanding that we need to meet people where they are, going into communities to bring the information and the vaccine in an approachable, respectful way. And that our healthcare system needs to be obsessed with addressing equities and disparities and not create the mistakes we've done in the past. And I hope that we can change our nation's current conversation from vaccine hesitancy or poor patient behavior to a national acknowledgement that the vaccine is new, people's questions and concerns are real, and that this is all part of strong decision-making process that I'm sure all of us have faced with the onslaught of new and constantly changing information. About today's webinar, we aim to start every webinar at United States of Care with an interview about someone's personal story, usually someone from the public or an advocate. Today, we begin with a different story for us, and it comes from a leading doctor and community leader. On February 5th, I interviewed our board member, Dr. Rhonda Meadows, about the current state of equitable impact and distribution, what keeps her up at night, serving the needs of the people, and her personal journey from moving to no to yes on getting the vaccine. And I want to call out to the audience that this sort of journey story, a story that highlights someone moving from no to yes and why, is believed to be really important when it comes to helping people move towards vaccine acceptance. Before you hear from Dr. Meadows, I'm honored to introduce 3 experts joining us today. Dr. Brodie is Executive Vice President and Chief Operating Officer at the Kaiser Family Foundation and Executive Director of the Public Opinion and Survey Research Program there. A distinguished public opinion scholar, Dr. Brodie's research focuses on understanding the public's views and knowledge on healthcare policy issues. And she has been a true leader in collecting data during this pandemic on what people need. Dr. Matt Mata is an assistant professor of political science at Oklahoma State University, where he's especially interested in identifying the social and political determinants of anti-science attitudes and investigating their policy impact. He is broadly interested in designing communication strategies that promote effective engagement between the public, scientific community, and politically contentious issues. And you can see how his expertise is so important now during the pandemic. Finally, Dr. Lisa Fitzpatrick brings us home, as she always does, about what it means to be working in community. Dr. Lisa is an infectious disease physician, CDC-trained medical epidemiologist, and founder of Grapevine Health, an organization focused on improving health literacy and patient engagement. Her career is impressive and has spanned research, clinical medicine, global health, community health education, and patient advocacy. Her obsession with talking directly to community members has never been important now, and you can always check out her work by Dr. Lisa on the Street on YouTube or Grapevine Health. And they're wonderful videos of her talking to people on the street. After Lisa, we will turn it over to you for you to ask questions of the panel. Throughout today's presentation, please submit your questions using the Q&A or chat function. And I did want to remind everyone that this event is open to the press. And now let's play the interview with Dr. Rhonda Meadows.
COVID pandemic just amplified what we were already being concerned about in terms of health disparities and resource inequities. Basically, it put to the forefront all of those things that we were not doing so particularly well with for people of color, people who are lower income or otherwise marginalized. With COVID itself, we saw early on not only an increased rate of exposure, but also an increased rate of more severe illness. So people were showing up more frequently in our emergency rooms, in our hospitals, and then we started noticing mortality rates were higher too. For Blacks and Latinx people, it was 3 to 4 times higher. For Indigenous people, it could be anywhere from 5 to, I think the Navajo people themselves reported 19 times higher, which was traumatic to the whole population. So we know that there's increased risk of exposure, particularly for people who are working in part-time retail or service-oriented jobs. But we also know that people with chronic conditions, particularly if they are people of color, and as they get older, that's like a triple threat in terms of their increased risk for more severe illness and mortality. Number one is to basically make sure that we are listening to those concerns and questions, not being dismissive. The past history of what has happened to people of color with respect to research, public health research, and clinical care cannot be erased or ignored. It can only be improved upon. And that is a reality that people will share with you, is basing their concerns on. There is also the more recent things that have happened, and as well as the persistent health disparities, implicit bias, and other challenges. These are longstanding. They've been there the whole time. Now, in the midst of a pandemic with a deadly viral infection, it has only been amplified. And then so we have to listen to what people are talking about and asking about. And then we have to make sure that we are there to give them what information we actually have. The second thing that I would say is be truthful and honest about what we do know and what we don't know. So unless we actually are honest in our answers and don't sugarcoat things, people become very suspicious and very unlikely to participate because they feel like you're not treating them with the respect and dignity that they deserve, and that they are really thinking adult people who are clearly able to make the decisions once they're given the right information. When they get in and they have questions, again, you have to respect their questions and their concerns. I'm just going to share with you a little bit here, okay? And that is this. I started in the hell to the no box. I am a physician, board certified, practiced for, we're going to say a couple of decades and leave it at that, okay? Vaccinated myself, vaccinated my children, vaccinated all of my patients, and did all those things. So I am definitely pro-vaccine, but I had serious questions about what a vaccine would look like and its safety and efficacy. So having the reassurance that there's actually scientists involved that has gone through much rigor and much study actually helped me tremendously. Now, I will also tell you that going from the hell to the no box to the no, to the maybe, and then finally accepting the vaccine myself took a lot of research, a lot of learning for me to get that level of comfort. And then I don't go to my family, friends, and coworkers unless I'm comfortable with what I know. Me being able to go from the no to the yes was one, gaining the information, the insight, and feeling comfortable and confident in it. The other is actually doing my homework and weighing the risk of the vaccine to the risk of the coronavirus itself. I know that I am personally at higher risk for the more severe illness, right? So that makes a big, important point for me. Same thing with some of my relatives and family members. If they are at higher risk because of chronic condition, their age, a whole host of things, that I'm going to make sure that they know that the risk of the vaccine, side effects long-term, something we don't know about, but the risk of the coronavirus itself is very real, it is very present, and it is right here today. And for my family and other families, people of color, we know this because we have suffered losses. So in my family alone, we've lost 10 people. And that is in less than a year's time.
Oh, I'm so sorry.
I have a large family from New York, Georgia, and Florida. We've lost, that is a generation.
Yeah.
I think what keeps me up at night is the concern that we're going to fall back, we meaning the industry, healthcare, public health, government, that will fall back to the way that we have distributed new vaccine and new medicines in the past. We do mass vaccination centers in places where the population is predominantly white or higher income or just professionals, as opposed to putting it into local neighborhoods, in community centers, in community college parking lots, in churches, wherever it is you want to go, but you have to go to the people to give them access. I'm concerned that the extra effort that it takes to have real conversations, to inform people and to be respectful of their concerns won't happen at a scale to give people of color confidence to continue to talk and build themselves up to get to the point where they will accept the vaccine. So I'm worried that we are just going to see a replay of that same movie that we've seen again and again. New treatment comes, new vaccine comes. They get distributed, people get them and receive them in general 2 to 3 years down the road. We look back and we say, oh my goodness, why is the severity and mortality rate still higher in this population when we know we have a vaccine that is effective? Why won't those people get the vaccine? And usually we come back around and we figure out that nobody went to them in any kind of a concerted or sustained way. Nobody actually asked them about their concerns, worked with them through those concerns, gave them the information they needed. Nobody made the extra step to make sure that not only is local access there, but the quality of care at those access points is of good quality. But you also have to address the fact that these are whole human beings who have other concerns, like vaccine clinic hours that are right when they're working. If they're paid hourly, they can't get off, they lose wages. They need their wages to eat, to pay rent, right? If they take off too long, I don't know how long your vaccine clinics and experience have been. Mine was pretty quick. But if you're waiting for a while, you can lose a whole day. You can also lose your whole job. And right now, when it's really hard economically, there may not be much options for them. So if you're the one who's in charge of your household, making sure people eat, sleep, have a place to live, you might think about, well, you know what? I have to weigh. What if I get sick from the vaccine? That's the other question, right?
Right.
Am I gonna actually be able to take off work? Will I have health insurance or coverage to pay to treat me? 33 million vaccinated. Of the ones that were vaccinated in the first month, we only have race and ethnicity data for 52%. Of that 52%, 60% who received the vaccine are white, 5% are Black, 11.5% are Latinx, and 2% are Native and Indigenous people. So you can see where there's an obvious hole and gap that needs to be filled, because otherwise we're going to be looking for long-term severity of illness and death rates impacting people of color.
Great. It's always so helpful to have framing and thoughts and hearing, Rhonda's personal story. We're thankful for that interview. I'll now hand it over to Molly Brodie to share information from Kaiser Family Foundation.
Hi, thank you so much, Natalie and United States of Care for having me here. Let me share my screen quickly. And somebody can give me a thumbs up that everyone can see it. Thanks, Natalie. I want to just really briefly give you a look at some of what we learned about where people are in terms of their comfort with getting vaccinated from our COVID-19 vaccine monitor. This is an ongoing research effort that's designed to make sure to scientifically represent the views and experiences of all Americans, but particularly some of the hardest to reach and most disproportionately affected groups in our country, the Black and Hispanic adults, those living in rural communities. We're listening hard to what people are telling us through their responses to our questions and in their own words. So to start with the question of people's willingness to get vaccinated, we think about the public in sort of three large buckets. There's the eager, there's sort of the middle group, the wait and see, movable middle, and then there's the outright reluctant. The good news is that we've been seeing evidence that the eager group is growing over the past few months as vaccination has shifted from being hypothetical to being an actual reality. So as of now, as you see here, 47% are eager to get it as soon as possible or have already gotten it, and that's up from about a third in December. The wait and see group, which I believe is one of the most important for us all to be paying attention to for the country to reach herd immunity, that right now stands about 3 in 10 of the public. I'm going to focus most of my discussion today on this group. And finally, it's important to note that about 2 in 10 are very reluctant. They either tell us they won't get vaccinated until they're required to, or they're definitely not going to get vaccinated, like we just heard, a hell no response. These groups are about the same size as they were in December, and I expect them to be the hardest group and maybe the last to move in any direction. Now, of course, intentions to get vaccinated vary across the population. In terms of the wait and see group, which I'm showing you here, young adults, Black adults, Hispanic adults, and urban residents are much more likely to say they're in the wait and see category than other groups. But while it's helpful to think about which groups are more or less likely to be in a given category, I think it is really crucial that we don't talk about any given group as a monolithic entity, because clearly there's varied intentions across every one of these groups. So for example, just look that among Black adults, the largest share, the 43% I have circled, falls into this wait and see category that we're talking about. But another 35% want to take it as soon as possible. For rural residents, you see that 42% are eager, 27% are in the wait and see group, and 28% are in the definitely won't get vaccinated group or only if required group. So we talk about rural residents as being very reluctant, but you can see that even among people in the rural communities of our country, 42% want to get it right away. I think this has real implications for how we think about talking and communicating within each population group. So what have we learned that can help us understand what the wait and see group is telling us and what's important for them? Well, first, we know that most people in this group do already worry that they or someone in their family will get sick from coronavirus. That's the 64% you see at that top on your left. We also know that more than half of this group believes that getting vaccinated is more their own personal choice rather than part of everyone's personal responsibility to being part of a community. So I think the conversations with this group really need to help them come to their own conclusion that the best choice they can make for themselves will be to get vaccinated, very much like the journey we just heard. We've also learned that those in the wait and see group have a variety of real concerns about the vaccine. They're much more likely to say that they're concerned about the long-term effects of the vaccine are unknown, that they might experience serious side effects from the vaccine, and that the vaccines might not be as safe as people say they are. Also note at the bottom, the 42% who say that they're concerned that they might get COVID-19 itself from the vaccine. And note that even within the wait and see groups, we see that concerns differ among other subgroups. So for example, Black and Hispanic adults who say that they want to wait and see are more likely than their white adult counterparts to say they're concerned about the safety and effectiveness of the vaccines. And you can see the numbers I circled at the bottom. About 6 in 10 of Black and Hispanics in this group say that they are concerned they might get COVID-19 from the vaccine. That's compared to about half as many as their white counterparts. We've also learned that hearing that even a small number of people had serious allergic reactions or short-term side effects causes those in the wait and see group to say that they're less likely to get vaccinated. For example, note that 60% of the wait and see group says that they will be less likely to get vaccinated if they heard that even a small number of people had a serious allergic reaction, and 50% say the same about short-term side effects. So addressing these worries head on is going to be important. And another challenge is that there are some serious misperceptions and myths about the vaccine that are circulating. They're circulating both unintentionally from those who just don't know, and they're circulating intentionally from nefarious actors. For example, about 1 in 5 have told us that the COVID vaccine, that they've heard that the COVID vaccine contains live virus, and they either believe that that's true or they're not really sure. Another 12% say the same about whether vaccines cause infertility. Overall, then, about 1/3 of the public holds at least one of these 3 misperceptions that we recently measured. Note that that grows to 41% among the wait and see group and more than half of the definitely not group. And finally, one more challenge that really needs to be on our agenda to tackle head on is that it is super hard for people to just get the basic facts about the vaccine from a trustworthy source. You'll note here that majorities, especially for the wait and see group, say they don't have enough information about when or where people like them should be able to get the vaccine, or even what the potential side effects are. Fully 77%, almost 8 in 10 of this group, want more information about this. So in addition to learning more about what people are concerned about and what their information needs are, we've also learned a lot about the actual messages that resonate most with this group. We find that hearing that the vaccine is really effective at preventing illness and protects you from getting sick, and that it's the quickest way to get us back to normal, resonates with the largest shares, particularly among the wait and see group. But also persuasive is hearing that millions of people have already been safely vaccinated. On the other hand, it's worth noting that that definitely not group is pretty dug into their opinions. They basically tell us that none of these messages would make them more likely to get vaccinated. Furthermore, we all know that messengers themselves are as important, if not more important, than the messages. At this point, we've only begun to dig into the most trusted messengers, but it should be no surprise that for virtually all of groups, people's own known healthcare provider ranks at the top. And for the wait and see group, healthcare providers and people's own family and friends loom as trusted sources. But as with concerns, not all messengers are equally appealing to all members of the wait and see group. For example, and perhaps not surprisingly, among Republicans in this group, the CDC and state and local health departments rank considerably lower than they do for Democrats, for example. And as important as I think representative quantitative data is to really help us understand and make plans for how to help move the country to herd immunity, there's really nothing like hearing straight from people in their own words. We have released for your own perusal the actual responses from a national random sample of over 1,000 people to 3 key questions. We asked people, what's your biggest concern you have about getting the vaccine? Is there one message or piece of information that you would hear that would help make you be more likely to get vaccinated? And is there any person who would make you more likely to get vaccinated if you heard that they had been vaccinated? Here, you just see a small flavor of some of what we learn as we actually listen to people in their own words. For example, I'm going to get the vaccine. I just don't want to be anywhere near the front of the line. Or the person who said, I know COVID is so devastating to human organs, but I'm concerned about not only the effectiveness of the vaccine, but about the long-term effects over years in my body, especially if I'm going to need this on an ongoing basis. They're worried about side effects. They're worried about all sorts of things. And I promise you that it's worth your time to read through everything that we heard from people, especially who they want to hear from. I think what the open ends really illustrate is it really does help us to take people's concerns and mistrust and information needs as valid and real. And that's up to all of us to help meet them where they are with this information, as Natalie said at the forefront. This is not the time, or there's not a challenge here to create the slickest messaging. We're not trying to sell a product here. This is about hearing and listening to people's real concerns and addressing those in a personal, trustworthy way. I think we're definitely in a dynamic situation. The real life events and announcements are impacting public's reactions. We should expect this to continue. The misinformation spread, both intentionally and unintentionally, is a real problem. The distribution process and how it continues and whether people feel like they can navigate it is going to matter a lot to whether we hit herd immunity anytime soon. The hesitant group is really not monolithic. We have to remember that. There's a large share in the movable middle, and they very much want a chance to wait and see what happens to those who take the vaccine ahead of them. And they want to hear their concerns and their worries addressed by the people they trust. And we know so far that this wait and see group wants their valid concerns about the safety, the side effects, and their worries about getting COVID itself from the vaccine addressed. They want messages delivered by trusted sources, and they want to hear that the vaccine is effective and protective, and that it has the most chance of helping them get back to any kind of life before they are even in the place of trying to come to the conclusion that getting vaccinated is the right choice for them and their family. So thank you. I'm looking forward to our discussion. And for now, I'm going to stop sharing and turning it over to Matt to take us further into this tough issue.
Thanks so much. I'm going to go ahead and share my screen here. Okay, well, thank you again for having me. And as Molly noted in her talk, COVID vaccine hesitancy is a really important problem. And I want to pick up where Molly left off by saying, here are some tested strategies that my colleagues and I and other academic research suggests might be effective at combating COVID-19 vaccine hesitancy and encouraging people to vaccinate. But before I do, I wanted to begin by before talking about what does work, what doesn't work, some of the myths that exist around COVID and other vaccine communication. And so, so often I and others hear phrases like this, that if only vaccine skeptics, if only we could talk to vaccine skeptics the way that medical experts talk to each other, with the presentation of facts and evidence, that this would be a way to encourage people to get vaccinated. Another way that we could think about this is by saying that if only people knew the facts, they'd be willing to side with scientific consensus and get vaccinated. But there's a couple of issues with that approach. The first is that this approach assumes that the reason why people reject vaccine safety is because they're unaware of scientific consensus, that they're unaware of the facts, how vaccines work, how disease spreads. And a lot of social science research suggests that this really isn't the case. Oftentimes, skeptics are aware of the scientific facts. They know their stuff, but they're nevertheless motivated to reject them. And that's going to be a big part of what we talk about today. They're motivated by social, political, and psychological concerns to reject the facts or interpret the facts in line with what it is they want to believe. In fact, we often find that people will use their superior understanding of the facts in order to validate their skepticism. I teach a course at Oklahoma State on misinformation. And one of the things I always tell my students is that if you want to know something about the curvature of the earth, ask a flat earther, because they know everything about it. It's not that they don't understand the science. It's that they're selectively using the science in service of arriving at a particular conclusion. And so what all of that means is that presenting people with the facts, fact-checking and debunking, isn't always going to be enough. And just a quick procedural note, you'll note throughout this presentation, I'm going to put screen grabs from scientific and academic articles. I do that so that way you can cross-reference the images in these slides if you're watching now or watching later on YouTube with those studies. And every study of mine that I'm going to talk about in this talk, I've made available to Ryan and Natalie. And so I'm happy to share those with you. So what we know from past research is that fact-checking can be effective. Fact-checking is most likely to change people's minds about scientific consensus, including vaccine-related issues, when those issues are not politically, socially, religiously, or culturally contentious, when those factors aren't necessarily dividing people's opinions about the science. And in those cases, fact-checking can absolutely work. But that's not typically the case for vaccine-related issues pertaining to the novel coronavirus and several other important vaccines. What my colleagues and I find in our research is that COVID-19 vaccination intentions are politically, psychologically, and culturally polarizing. And just to give you a quick example of what this looks like, we know based on the research that Molly cited as well as other public opinion polls that somewhere between a fifth and a third of Americans, depending on the survey and when it's taken, might refuse a coronavirus vaccine. But coronavirus vaccine refusal is not equal throughout the population. Some people are more likely to refuse vaccination than others. We know, for example, from our research and others, that women versus men are more likely to intend to not vaccinate. African Americans and people of color in the US are less likely to intend to vaccinate than white folks. And what I've put on the right-hand side of the screen here to kind of serve as a motivating example for this talk is the possibility that we are divided by political ideology with respect to whether or not we intend to vaccinate. And what this graph shows is that early on in the pandemic, Democrats and Republicans intended to vaccinate at roughly equal rates. But as the pandemic wore on, and particularly in response to former President Trump's rhetoric downplaying the severity of the coronavirus, we tended to see growing partisan asymmetries, such that Republicans became less likely to intend to vaccinate. And that makes sense. Why would you vaccinate against an illness that isn't all that bad, or if we're turning a corner? That, of course, changed in the early fall, notably following the vice presidential debate. Now Vice President Kamala Harris expressed some skepticism about whether or not she would receive a vaccine that was approved by the Trump administration. And what we see is a dramatic reversal in that time period in vaccination intentions between Democrats and Republicans, such that Democrats now became less likely to intend to vaccinate. And following the election of Joe Biden to the presidency, we've kind of seen a return to what we saw earlier on this summer. The reason I share that example is because I think it's useful for thinking about the ways that social factors, politics, and psychology can influence our decisions to vaccinate in ways that have nothing to do with the science itself. We also know, for example, that while safety concerns loom large for African Americans and people of color in the US, our research suggests that access concerns are also a major factor regarding why it is that especially people of color in the US are less likely to intend to vaccinate than white folks in the US, which is a point that I think is kind of underplayed in some of our discussion about vaccine hesitancy. And I'm happy to talk about some of the research that my colleagues and I have done on the correlates and determinants of vaccine hesitancy in Q&A. So now I want to get to talking about what it is that we can actually do to move the needle on COVID-19 vaccine uptake. And I'm going to share briefly some insights from research that my colleagues and I have worked on in the past and that we're working on right now. And specifically, I want to introduce an approach to doing this, which is known as the science of science communication. And the science of science communication basically works like this. The first thing my colleagues and I try to do is to determine how many Americans hold views that are inconsistent with the best available scientific data. We typically do that using correlational survey research, public opinion polling. We then try to determine why some people are more likely than others to be vaccine hesitant or to hold views that are inconsistent with the science. And then critically, we use what we learn in stage 2, the reasons why some people are more vaccine skeptical than others, to then inform communication strategies that are trying to meet people where they are, that use that information to encourage vaccine uptake. So to give you a quick example, my colleagues and I found in our previous research that one factor that underlies people's decision, especially parents' decision to refuse MMR vaccination for their children, are feelings of moral purity. This idea that your body is a temple and that putting any foreign substance into it is a violation of bodily sanctity. What we try to do in this situation is to tell people, look, we totally get it. Vaccines are a foreign substance necessarily entering your body. And we understand why that might be a violation of these feelings. But you know what else is a violation of bodily purity? Measles, mumps, and rubella, the very diseases that these vaccines were designed to protect your children against. And we find that when we make that connection with people and we meet them where they are, they're more likely to hold views about MMR vaccine safety that are consistent with scientific consensus. And so what my colleagues and I have been trying to do throughout the coronavirus pandemic is to apply those insights to understanding COVID-19 vaccination. Just a couple examples of where we've done this. In a recent randomized controlled trial that we published a couple of weeks ago, we found that personal narratives highlighting the risks of not vaccinating, that is to say, the possibility that you could develop severe illness from COVID, as well as the social benefits of vaccinating, getting the COVID shot in order to help those who are immune compromised, were roughly effective for both Democrats and Republicans alike, thinking back to our motivating example from a few slides ago, to encourage people to intend to vaccinate. And we found as well that advice coming from medical experts on the personal health risks of not vaccinating was also effective for both Democrats and Republicans at getting them to vaccinate. Less effective, somewhat surprisingly, I think, but less effective were emphasizing the macroeconomic costs of not vaccinating, vaccinate in order to help the economy, in order to get back to work, as well as medical expert assessments of the collective public health risks of vaccine refusal. Additionally, we know, again, as I mentioned a few slides ago, that Republicans at this point in time are a bit less likely than Democrats to intend to vaccinate against COVID-19. And a messaging attempt that I am working out in a working paper that hasn't yet been peer reviewed is to try to talk about the accomplishments of the Trump administration in order to encourage Republicans to get vaccinated. If we recast the Biden administration's vaccine rollout responsibilities and obligations, and instead talk about the foundation that the Trump administration laid for this. And what I find using this approach, and again, keep in mind, this is a working paper, it's something that we're working through, is that being told about the previous administration's accomplishments makes Republicans a bit more likely to believe that the vaccine will be rolled out safely and fairly and equitably. It's less effective at changing minds about the vaccine or intentions to vaccinate, but we know from previous research, as well as research from the Kaiser Family Foundation, which we just talked about, that typically we've seen some correlational evidence that when confidence in rollout increases, so too do opinions about the vaccine, or positivity, I should say, about the vaccine, and intentions to vaccinate. So that's something to potentially keep an eye on. And I'm actually going to just skip ahead a couple slides, so I know I'm running short on time. But another thing to consider when trying to win over vaccine skeptics on the ideological right is to employ skeptics who have seen the light, so to speak, in communicating vaccine safety. Joni Ernst, for example, had some very derogatory things to say about doctors treating patients with COVID-19, and yet she chose to vaccinate, emphasizing those types of decisions, irrespective of how it is that we might feel about them, might encourage individuals who are otherwise vaccine skeptical to listen to people who share their political views, who have some point of common connection with them in areas unrelated to the science and the vaccine itself. So just really briefly, putting all of this research together and offering a few lessons that I think we can take away from it. The first is that there's no one size fits all to improving COVID-19 vaccine uptake. That's because there's a lot of different reasons why people might intend to refuse a vaccine if we're meeting people where they are. This implies that we're going to need lots of different messaging strategies in order to do it. The second is that pluralism is key, both with respect to the messages we try, as well as the individuals who source those messages, the messengers, so to speak. Some people are going to be more credible communicators than others, in part because what we mentioned in point one, that there's a lot of different reasons why people might choose to reject a vaccine. And if we want to meet them where we are, different people are going to be better at doing that than others. And then finally, we need to make an effort to understand why it is that people reject vaccine safety. This is why the work that Molly and others are doing is so important. Because if we can understand why it is that some people are more likely to refuse vaccination than others, we can use that information using the science of science communication approach that I mentioned earlier in order to create messages that meet people where they are and hopefully encourage vaccine uptake. So thanks again for having me. Here's my contact information. And once I can get back into the Zoom here, I am going to turn things over to Dr. Fitzpatrick.
Thank you, Matt. Hello, everyone. It's my job to give you a break from data slides. Next slide, because I want to talk about the context around what's happening in the community, what people are saying about this vaccine, how they feel about it. And I want you to get a sense of hope based on what I'm hearing from people. I'm so happy. Several of you listening are from the press, because some of you may have even called me to ask me about vaccine hesitancy. And I may have said to you, I think we should change this narrative. We shouldn't be talking about vaccine hesitancy. We should be talking about what I call the vaccine acceptance continuum, which is basically what Mollyann described. Because according to her data, 80% of the people are somewhere on this continuum toward accepting this vaccine. So we should be focusing, my strong opinion is that we should be focusing on that. And I agree with the focus on the 43% who are in the wait and see category. And those are the folks I'm talking to actively. So I want to share some information about what I'm hearing. So I only have 2 slides. So I want you to see some of the activities that are happening in the community so that you understand the context in which I am learning and becoming or starting to understand this information. So I'm physically on the ground with people. I'm in webinars with community members at least twice a week, hearing people's concerns firsthand. But before I talk about that, for those of you who don't know, I am a Moderna vaccine trial participant. So this is the picture of me in the middle. I've been sharing my journey on social media, trying to offer some transparency because we don't talk about clinical trials. I'm happy the public is now tuned in and learning about clinical trials, but before now, the best time to educate people or to build trust with people is not during a crisis. So I think that's part of the reason we're failing in some ways. But in the absence of that, I thought my story could help provide information and education people are seeking. You might be wondering why I decided to participate in a vaccine trial. I had no intention to do so, but on one of my strolls in the community, I encountered a man who said to me, well, first he said, I have no interest in the vaccine because that's Trump's vaccine and I don't want anything to do with it. So similar to some of the comments you heard even from Dr. Meadows. But after our conversation, I said, well, before I leave you, what would make you comfortable taking the vaccine? And he said, well, if I could see other Black people associated with it. So after that, I completed the form and was accepted into the trial. And that's how I became part of the trial. And so it's been very interesting to talk to people about that on the street. People who are in this 43% who come up and say, oh, I have no interest in this vaccine. The first thing I do is try to help people separate the politics from the science, because that's what's happening. People are conflating messages they're hearing from politicians and making decisions, as you just heard from Matt, about whether or not they want to take this vaccine. So trying to help people separate that out. And I might ask, well, I'm a physician. Would you call me to fix the plumbing in your house? Well, it's pretty obvious you wouldn't. So trying to provide different contexts for people to think about how they're making these decisions has been pretty useful. So what am I hearing? The most common questions I get, and I've written about this in case you haven't seen it. They're the same questions Mollyann shared. Is it safe? What are the side effects, which I see as related, but the community sees them as separate issues until I explain how a clinical trial works and what we're looking for. And also this notion about going first. Well, maybe I'll just, I'll wait and see. But I remind people that if you think back to when the first person received a coronavirus shot, the vaccine, it was actually almost a year ago. And when I remind people of that, they realize, oh, wow, because some people have even said to me, well, I'm going to wait a year to see what the side effects are, and then I'll think about getting the vaccine. So when I say, well, March, the first part of March will be a year. So how, what do you think about it? What do you think about that now? And they may have other questions. So I share my experience in the trial. I had side effects. I had a very uncomfortable night with lots of body aches and a low-grade fever. I was tired, pretty fatigued for a couple days. And I share that with people and help them understand the phases of the vaccine trials and why I felt comfortable even with these side effects. These side effects were identified during phase 1. So again, helping to educate people about the different aspects of the trial really helps provide the information and support they need to make a decision. And finally, I have been getting before I go on to the Ask the Doctor sessions, I want to talk to you a little bit about that. But I want to ensure the people I talk to on the street, no one is asking me about Tuskegee. Because this is also a question I get. Well, do you think people are hesitant because of Tuskegee? They're not. People know about Tuskegee, but they don't know the essence. They don't know exactly what happened. In fact, when I tell people you're concerned about this vaccine, and if Tuskegee somehow comes up in the conversation, I remind them there were no vaccines associated with Tuskegee. So when you talk to people about what the real mistrust, the root of the mistrust, it's really about how people are treated in our healthcare system today. and they have family members. My company is called Grapevine Health because a lot of health information is transmitted organically at the bus stop, at the dinner table, through friends and family. This is where people are getting trusted health information. So we want to help augment that and address the misinformation that's on the grapevine. So when I tell people about my experience and then ask them to tell other people, this is how we are also hoping to spread information about the trial. But related to Tuskegee, when I talk about the vaccine and the vaccine not being related to Tuskegee, someone will tell me, well, when my grandfather went to the hospital, we never saw him again. He died in the hospital. So I think these are the things we should focus on now. What is going on within our healthcare system in 2021 that is making people distrustful of the people who are delivering healthcare? Doctors are one of the most trusted sources of information for people in the community. However, even doctors, I've encountered a few doctors who are still somewhat reluctant. And I think this is what I'm seeing, and this is me talking, all qualitative information. I think this is related, this is a generational issue. So in one of the webinars I delivered a few weeks ago, I talked about my research trial experience. I answered all the questions, and someone said, well, Dr. Lisa, I just met you, but I've been with my doctor for over 10 years, and my doctor told me not to take this vaccine. Why would I trust you over my doctor? And I have to admit, I was a little caught off guard by that, but I did a little bit of homework, and I also reached out to this person to get more information. And it turns out his doctor was in his 7th decade. He'd never been involved in research. He'd never worked in an academic setting. And I think this is also part of the reason we are seeing this disconnect with some providers, because the public sees doctors and they conflate us with researchers and scientists and even people in the lab. Well, because you're a doctor, you must understand all these things. And it's not true. So I think there is a need to better educate providers also, particularly providers who've never practiced in an academic setting or who are not familiar with research processes. And when I thought about it, the reason I felt comfortable, in addition to knowing the phase 1 safety data, I felt comfortable participating in a research trial because I knew the investigators at George Washington University, and I called them up and said, hey, what's going on? What is this messenger RNA? So I had access, and I think that is something that's missing. And we need help and we need support to help bridge that gap between providers in the community who may not have such easy access to researchers who really understand and can credibly talk about clinical trials and vaccine research. So finally, the next slide is just a segue for me to talk to you about these Ask the Doctor sessions. So I started these Ask the Doctor sessions 4 weeks ago. We have a speaker bureau. Grapevine Health has a speaker bureau, and we are rotating on Tuesday night to answer questions directly from the community. There's a lot of information and education out there, but it's usually me talking to someone or some scientist or researcher or clinician. They're didactic or they're talking to colleagues. I wanted community to be able to reach in directly and talk to a provider without a filter. So we started these Ask the Doctor sessions, and at the beginning of every one, there's a poll. So I'm not sure if you can see this. I hope you can. But the poll is always asking, we always ask people if you will get the vaccine. And so for this webinar, most of the attendees are seniors. So 61 or 67% are over the age of 61. But look at the third question. Do you plan to get a COVID vaccine? Look at how many people said no way. 0. 33% not sure. So I think this is encouraging, and this is basically what we see every week so far. It's also reflective of what I'm hearing in the community. The people who are not sure, they are seeking, they are questioning, they want answers to their questions. And so this is the service I am providing in the community. I understand the data, I understand research. I'm an infectious diseases doctor. I can understand these concepts, but the community doesn't. So I've chosen to serve as a bridge between the community, researchers, scientists, and really help move people along this continuum. And I think we're doing okay. And finally, I'll say the 80%, if we get the 80% who are on the continuum, we'll get out of this pandemic. So thank you for listening. And I really hope those of you who are in the press can help us shift this narrative toward acceptance, because who wants to be part of a negative narrative? And I think as people see more folks who look like them that are taking this vaccine, we will only see these numbers continue to increase. So thank you very much. And it was a pleasure being here. Thanks for asking me.
Great. Thank you, Lisa and Molly and Matt. I invite you guys back on screen, and we will do a lightning round of questions, maybe go a little bit over time because we've had some really good ones, but we'll keep this quick. Something that has come up in the questions, but also as you think about a narrative or even how we talk about it among our friends, this idea of back to normal. Is this a motivator to people to get the vaccine? It's kind of hard to imagine normal exists anymore. So what if, maybe starting with Lisa and then Molly and Matt, how do we think about this as a helpful narrative not to get to vaccine acceptance?
Well, I mean, as Matt mentioned, it's not one size fits all, right? So I think there are some people that message will definitely resonate. I lectured for a GW class last night and this same question came up. And someone said, well, we're never going back to where we were before. And actually, I don't believe that, because I look at 9/11. We said the same thing after 9/11. It might take a while, but we will slowly revert back to where we were. So I think, yes, it can be a motivator, but for most people I'm encountering, they just want information. They want credible, trustworthy information.
Yeah. Oh, go ahead.
I was just gonna say, in the interest of time, I'm just going to say, yes, Dr. Lisa, of course, you got it exactly right. And the other thing I would say is that this does, I think, complicate the communication right now, because the science is not yet caught up to this expectation that once you're vaccinated, you don't need to wear masks and you're not a risk anymore. And I think, slowly there was some, hopeful science in the last week or so. And I think as that science catches up, we're going to be in a better position to actually speak with more clarity on that. And I think that will be really helpful. Sorry.
Yeah, I just want to echo everything that's been said before, and to note that when my colleagues and I have tried the get back to normal frames, those haven't been as successful. And I think what's going on here is that that's a much more abstract reality. The possibility of getting sick, possibility of getting someone else sick, I think that's very tangible. What is normal? How do we get back to it? And how does a vaccine get you there? I think it's more nebulous. And so I think that might be why.
So perhaps it's talking more about back with our family, back to school, back to work is a way we can talk about it without using normal, unless that does motivate them.
Sure.
Really interesting to hear that for Republican, wait and see Republicans, hesitant Republicans, this idea that Trump helped, the vaccine was truly created under the Trump administration, and now through another administration is being administered, and knowing that is also, it scares off a lot of people of color and others. How do we, Molly, you just mentioned the complication of messaging and talking about this publicly when something really works for one population and really turns off another. Any more thinking or advice or about that topic?
Well, I think this is why it's just so important to really not think in any monolithic terms, right? Everything about this pandemic, everything about how we have to talk to people has to be really on an individual basis. And just really, as you started this session off, meet people where they are. I will say that one thing that we know about, the Republican sort of perspective on this is that they think that it's been exaggerated. And so again, it sort of suggests another avenue of like, this scary thing might work for some populations, but it doesn't work for others who feel like that's not actually what the reality has been. So this is micro conversations. I don't know how else it's, again, back to, this is not some big flashy national campaign that goes on the Super Bowl, right? Like, this is not what we're talking about here. We're talking about the kinds of conversations Dr. Lisa was just talking about. It's hard, it's resource intensive, it's necessary.
Yeah, and if I can just briefly piggyback on that, we live in an age where micro targeting is possible on social media and other platforms. We don't have to rely on national campaigns and ads aired during the Super Bowl. As long as we know who our audience is and why it is that they're skeptical, we can, with razor-like precision, find members of that skeptical audience and try to give them the messages that we think would be most effective.
Lisa, how has it been talking to folks in the community when it's hard to get a vaccine right now? And so a question that's come in is, how do we think about message timing and messaging when access is still kind of tough for a lot of places in the community? And it's, we're still in these smaller groups that are able to be prioritized to get it.
Yeah, it's really unfortunate because the rollout should have been planned around the same time the vaccine studies were executed. So, there's a saying, the best time to plant a tree was 20 years ago. The second best time is now. So I think it's not too late. We can do both at the same time. But I think, again, these trusted messengers are the key. They're all over. We just have to find them, and they can ask for patience. They can help educate people at the same time, but also their voices need to be heard at these policy tables. And I'm so glad someone like Andy is now at the White House who can, carry these messages forward. But it's a tricky situation, and definitely needs to be managed. But I'm still optimistic that despite the mess, because I think a lot of the skepticism came from the previous administration, if I'm being honest. And I think people feel like, they have a sense of help is on the way. It's a little bit of a mess, but I'm willing to wait until I can get access. So let's just figure out how to get them access.
That's great. Any lightning round, any last words for the media, for our reporter friends on what's your round robin, Lisa, advice to covering this issue?
I mentioned it in my remarks, and that is, let's shift away from hesitancy and start highlighting acceptance and focus on this 43% Mollyann told us about, the same group I'm seeing in the community. And finally, I'll just address this question I'm seeing from, I think it's Danya Alarcon. I'm sorry if I mispronounced your name. Yes, there are few of us, but we are not the only trusted messengers. Just because you are white doesn't mean you can't talk to a Black population. This is really about building trust. Are you listening? Are you incorporating the feedback you're getting from people? Those are the cues people are using to decide if they trust you. Is your report, if these are reporters, is your reporting accurate, and is it genuine and authentic? Those are the things people are looking for. So it doesn't have to be a Black person. So all of us have to help solve this problem because there aren't enough of us.
Thank you. Molly?
To tee off what something Dr. Lisa just said is, I get the purpose of journalism is to report the news, but there's good news and there's bad news. And I feel like sometimes in this conversation, yes, there's a lot of challenges with distribution, and yes, the disparities are getting worse, and there's all sorts of challenges, but so there's also some hopeful notes. There's a lot of vaccines that have already gotten out. There's tons of vaccines that have been given with no side effects. And as much as we report on the occasional bad side effect, reminding people that there's how many millions of vaccines already been given out over the world with no side effects or low side effects. I think it's just getting that balance right and getting that information out and not forgetting both sides when you have such a short news. I get it. The news holes are short. The ability. I mean, I get the challenges, but just really to remember that.
Yeah, if I can share just one parting piece of advice, one of the things that I've been trying to do to motivate new efforts to try to reach the vaccine hesitant is watching videos of people who formerly believed in QAnon conspiracy theories and have seen the light and have changed their minds. And in those videos, I have never once seen someone say, you know what, I came across this piece of evidence that was just so damning, I had to change my mind. Fact checking is important. And when I talk to journalists about this, I totally understand the need to fact check, but there's an equally important need to try to understand why some people are vaccine hesitant and to affirm those views, not to debunk, not to cast doubt on the science, but to say we understand why it is that you're skeptical. Here's why you should vaccinate anyway. So fact checking, absolutely important, but I don't think it should be the only thing that we do.
Great. And I know from Molly's research and Matt's and Lisa's that they even picked up on keywords right there about talking about the minimal side effects, the importance of getting back to family and loved ones, and other nuggets that are directly from their research on what motivates people. United States of Care has summarized a lot of that in our interested parties memo. So we are trying to pull out what is the research saying and how can we talk about this. I want to thank the 4 panelists for coming on today with Rhonda and sharing her story, and really thankful for everybody spending a little over an hour with us. I encourage everyone to go to our website, unitedstatesofcare.org, to access resources referenced today. We'll make sure to send out an email with summarizing and providing links to a lot of this research as well as the video. And if you're inclined, please consider donating to United States of Care and supporting our work. And please be safe, take care, and have a great day.